Good morning, Sean here, and today I'm going to try and decode your clinic letter for you. So if you're under an oncology clinic, there's a good chance that you receive letters with a load of medical jargon or gobbledygook at the top, and I'm going to try and decode that for you today. So let's jump in. So here's an example of a letter that I've just made up for an invented patient. And this is what your letter might look like. So at the top you'll have diagnosis, you'll have prostate adenocarcinoma or carcinoma or cancer. That just usually refers to the fact that it's cancer. It may specify the cell type, so adenocarcinoma is the type of cancer cell. Somewhere on the top of your letter there will be something to do with PSA. It may have PSA in front of it, which means presenting PSA, or PSA, which means incident PSA, and then a number after that. So that's the PSA that you had when you were diagnosed or when you went to your GP, and that helps to risk stratify the type of cancer. Then somewhere in your diagnostic box you might have reference to MRI, and it might have indices such as looking at the size. So here I've put 44 cc. You might also see ml, such as 30 mil, and that again just refers to the size of the prostate. The size can affect the type of treatment that you are offered. You may also see something to do with IRADS4. So this is a scoring system devised by our radiology colleagues that gives us an idea as to the likelihood of clinically significant cancer, with 1 being low probability or chance of significant clinically significant cancer, and 5 being highly likely clinically significant cancer. And then there I've put left PZ, that stands for peripheral zone. This just refers to the anatomical location of the lesion or the cancer. You might not see that, so some types of cancers don't have any specific location, but it might be potentially in different parts of the prostate or lymph nodes. Then you might see something to do with Gleason, and here I've put 4+3 and 3 out of 11 cores. So what this means is you've had your biopsy, and if you do have a biopsy, they take the tiny little samples, and they're called cores, and then the pathologist looks at those cores under the microscope and grades them in terms of how aggressive they look under the microscope, 5 being the most aggressive type of cell, which may potentially grow a bit quicker, and 3 being more indolent types of cells. And the 2 scores mean that the 2 most common grades that they see, and they will often combine that to an overall score such as 7, 8, 9. And again, that will help determine what treatment you are offered. You may or may not have had a PSMA PET or a different type of PET, depending on local availability, and this will sometimes talk about avidity. So what avidity means is that you've been when you've had the scan, you were injected with a special type of dye, and that's attracted to bits of cancer or lesions of interest. And what they're looking to see is that if there is any activity outside the prostate or within the prostate, for example, to lymph nodes or distant parts of the body. You may also see something about Qmax or flow studies, so that's to do with your urinary flow or your waterworks. So all of these taken together help your team decide what's the best treatment for you. As ever, I've put some trusted sources in the comments below.